Good afternoon, everybody. Thank you so much for joining us today for this DEBAKEY live session, in which we're going to be talking today about coronary heart disease risk in people of South Asian ethnicity, particularly focused on people living in the US. And we're going to have a fantastic panel of speakers today joining us, talking about genetics, metabolism, culture, and social determinants of health as potential factors that might explain the excess risk of CHD that we see in epidemiological studies in South Asian populations. So I want to thank everybody for joining us today. I want to make sure that everybody participates if they have questions for us. So you can join us using the web. You can go to paulev.com and send your question, you enter in DEBAKEY, or you can join us by texting DEBAKEY to 37607 and send in your question. We're going to have a questions and answers part at the very end of this event, and if for whatever reason we run out of time, we're going to be following up on Twitter, making sure that we address any questions that you might have about this topic. So we're looking forward to this fantastic discussion. We're going to have 4 superstar speakers today joining us. We have Nadia S from New York. She's Associate Professor of Population Health in NYU, and she's one of the PIs of the MASALA study. Thank you so much for joining us. She's going to be talking about SDOH in South Asian individuals. We have Dr. Priyanka Satish. She's a superstar cardiology fellow here in Houston Methodist. She's going to be talking to us about culture and potential cultural traits that might increase CHD risk in South Asian individuals. She has been leading several research efforts here in Houston Methodist in the last month with us. We're also going to have Dr. Anand Rohatgi, who is an associate professor of medicine. He's the director of professional development, cardiovascular professional development in UT Southwestern. He's an expert in metabolism and HDL function and metabolomics in South Asian populations. And we're also going to have Dr. Amit V, who is he's an expert in genomics. He's leading efforts using the UK Biobank and other databases to understand the genetic basis of excess risk of CHD in South Asian individuals living in the UK and elsewhere. He's the Associate Director of the Cardiovascular Disease Initiative in the Broad Institute. He's the Associate Director of the Precision Medicine Unit in the Center for Genomics Medicine, and he's a cardiologist in MGH. So thank you everybody for joining us, and thank you to our speakers. As a background to this event, we wanted to share first his brief introduction with you. We're going to be talking about South Asia for several reasons. First of all, we're interested in this population, South Asians, because they are a large patient population here in Houston Methodist. We are taking care of a large South Asian community in our area. Also, because part of our workforce is of South Asian ancestry, we have several professionals who are from India, Pakistan, Bangladesh, and so on. And especially because, as you know, South Asia comprises almost 25% of humankind. So definitely this is a very relevant topic. We're talking about a very high impact area of research. When we talk about South Asia, you know that we're talking about these countries here on the screen. So it's India, Pakistan, Bangladesh, Sri Lanka, Nepal, Bhutan, and Maldives, which, as I mentioned, they're home to 1.9 billion people. And we also have this large South Asian diaspora, which is close to 30 million people living elsewhere. So definitely a large community, a large population. And it's not only that it's large, but actually it's growing. It's growing both in South Asia and elsewhere. If you check on the left upper side of the screen, you can see the population growth in South Asia in the last 70 years. You can see how it's been a fast and steady growth in the area, and continues to happen. So we're expecting large population increase in the coming decade. On the right side of the screen, you can see for the United States the data for the South Asian communities living here in the US, and you can see large increases in the population, particularly for Indians, who are the largest group of South Asians in the US. But you can see how the percentage change has been a large increase in the last 7 years in almost all subgroups. And on the corner, on the bottom left, you can see data also for other countries. For example, from Catalonia in Spain, that's where I trained in cardiology. That's where I started to work with South Asian patients. And that's the reason why I got interested in this area of research. And you can see how the population, the Pakistani community in Catalonia, has been increasing really fast since 2002 to 2012. The increase has been fourfold and continues to be the case in recent years. As a consequence of this process, right now, Asian Indians, they comprise the largest Asian population in the US. It used to be Chinese people, but right now, after in the latest US census in 2019, we have the data, the most updated data here in the screen, and you can see how Asian Indians have become the #1 group among Asians in the US. And the other reason why we're interested is because studies, both in the US and elsewhere, they suggest that people of South Asian ancestry, they have an increased risk of coronary heart disease compared to most other racial ethnic groups. This is, for example, a news report in the Washington Post. This has been echoed in almost all major newspapers in the country. And you can see also the data from the Global Burden of Disease and how they show how CVD mortality continues to increase in the area, particularly in northern India. But this is something that has been discussed in multiple studies. On the left, for example, you have data that was published in JAG in 2013. And this is a study that actually uses data from the 1980s and 90s, so it's an older study, and you can see how the association between South Asian ethnicity compared to non-Hispanic whites and CAD events over during follow-up, you can see this multivariable adjusted hazard ratio of 2.4 compared to non-Hispanic whites. And on the left bottom part of the screen, you can see compared to any other racial ethnic group, South Asians shoulder a clearly excess risk of CAD, up to 3.3 compared to Chinese individuals. And these are analyses adjusted for multiple other cardiovascular risk factors. But if we use more recent data, like on the right of the screen, you see the study published recently in Atherosclerosis by Persnani and colleagues. And you can see how compared to non-Hispanic whites, individuals of South Asian ancestry, they have a twofold odds of CAD events compared to this reference group. So definitely, regardless of whether we use older or more recent data, when we use cohort studies, we see these trends portrayed consistently. As I mentioned, these trends have been portrayed in major newspapers around the country. On the left, you see Alka Kanaya, who is a friend of all of us and a collaborator, a PI of MASALA study, and she's talking in the New York Times about the high rates of CHD in South Asian individuals and why South Asian individuals have CHD events earlier in time compared to other groups. And on the right, you see this report in the Chicago Tribune. They interviewed the other PI of MASALA together with Nadia and Alka Kanaya, who is Namrata Kandula. And they talked about this patient, Munaf Patel, who at age 43, he already had 2 myocardial infarctions. This is not an exception, but actually this is a pattern that we see in many of our patients, both here in the US and elsewhere. So definitely a lot of interest. And one of the reasons is because this is not a phenomenon only in the US. This is something that happens also in many other countries. This is actually a global phenomenon. And you can see how studies have been published in many other countries, including Canada, the United Kingdom, the European Union, many countries, including Spain, where I used to work and do my research with the South Asian population, the Middle East, South Africa, Singapore, Fiji. So definitely a global phenomenon that has attracted attention from epidemiologists from all around the world, including big names like Dr. Marmot, who is one of the fathers of modern epidemiology in the UK, studies in Canada, studies elsewhere. And this, for example, data in Catalonia that we published a couple of years ago in the journal Heart, in which we use data for 6 million adults using the region-wide registries that we have there. The purple line is the line for South Asians. The dot line is the line for the native local population. And the other lines are for other groups, immigrant groups from low and middle income countries. And you can see on the top, we have data for diabetes in both men and women. And on the bottom, we have data for CHD in both men and women. And you can see how those curves separate, they're separated early in time. And you can see how the burden of CHD is markedly higher in those South Asian immigrants living in Catalonia compared to the local population of the native local population. And the differences are particularly striking for women. You can see how those differences for diabetes, for example, at some age groups, we're talking about a 7-fold higher burden of diabetes in South Asian women compared to Catalan local women. And also the differences for CHD are definitely striking. Even though South Asians, they tend to be lumped or combined in a single group when we present these kind of studies, actually we're seeing in recent analysis how CHD is actually pretty heterogeneous within the South Asian population. And you can see how this is going to be important because, for example, here in the US, even though most of South Asians, they are mostly Indian, we have large communities also of Pakistani and Bangladeshi individuals, and these communities are growing fast in our country. And also in other countries, for example, in the European Union, you can see how those groups are pretty diverse. In the UK, which hosts the largest South Asian community in Europe, not the European Union anymore, but in Europe, you can see how India represents the largest South Asian group there, but also large communities of Pakistan and Bangladesh. And in countries like Spain or even in Greece, more clearly in Greece, you can see how Pakistanis are actually the #1 group, followed by Indians, but also large communities of Bangladeshis. And this is going to have important implications in terms of the overall risk of the South Asian community living in that country. And recent studies, but also old ones like the Interheart study that was published in 2007, specifically focusing on South Asian populations and South Asian countries, and they showed that Pakistan and particularly Bangladesh, they had a higher burden of most cardiovascular risk factors compared to India, except for diabetes. And this analysis, that is one of the studies that Dr. Nadia S has been leading in New York, you can see how the trends, even though it's a small study, the trends suggest that the burden of cardiovascular risk factors in Pakistanis and Bangladeshis is higher also here in the US compared to the Indian population here in the United States. You can see how Bangladeshis, they rank first in almost all risk factors assessed, followed by Pakistanis, and the third group would be Indians. These analyses are consistent also with larger studies in the United Kingdom, like this study by Julia Happisley-Cox and the QRISK-3 team, in which they showed that among women, Pakistanis would be the highest risk subgroup among South Asians, and among males, you can see how Bangladeshis followed by Pakistanis would have the highest risk, whereas Indians would have a lower risk within the South Asian population. And that's exactly the same pattern that we've seen in Catalonia in this most updated analysis that was led by my colleague and friend Priyanka Satish here in Houston Methodist, using data again from Catalonia, in this case for 121,000 Asian immigrants, first-generation immigrants living in Catalonia. And you can see when we use this disaggregated data for the South Asian groups and other Asian groups, you can see how among males, clearly Bangladeshis, they had the highest risk of CHD, followed by Pakistanis, whereas Indians, they had almost exactly the same burden of CHD compared to the local Catalan population. And on the right, you see the data for women, with Pakistanis ranking first, which is highly consistent with the data that I showed you for the UK, which suggests that we are not seeing a very specific signal in one of the countries, but actually seems to be a consistent pattern across environments. And there have been multiple calls to action based on these analyses, not only these recent studies, but other classic studies like Interheart and others. And this is a statement by the American Heart Association published in 2018, a very famous publication by Annabelle Bowman and others, Annabelle Santos and others. And you can see how they were calling for further research in this space. They were definitely stressing the need for further research to understand what are the mechanisms leading to this excess risk. We have a lot of studies already showing an excess burden of CHD, but we need to understand what is driving that excess risk so that we can inform more effective interventions. And there are also congressional initiatives going on, like HR 3131, which was passed in the House of Representatives in September, and it's going to be discussed in the Senate soon. So the big question here is why? Why we see this excess risk in South Asian individuals, and definitely having this knowledge, both in South Asians overall and specific subgroups, can help us inform those interventions that are going to be very helpful, trying to reduce the risk both here in the US with South Asian communities and also elsewhere. We're talking again about 2 billion people, so definitely a high impact intervention if we are able to understand what is driving this excess risk. And that is the reason why we wanted to have this event today, having the opportunity to discuss with this, as Dr. Nasir would say, these luminaries in this space, experts in very different areas, complementary areas of expertise. So we're going to have, first of all, we're going to have Dr. Amit Khera, who I already introduced. As I mentioned, he's one of the leaders of cardiovascular genetics in the US, and he has been leading really interesting research recently in the space of genetic risk in South Asian individuals. So, Amit, it's a big pleasure to have you today with us, and we're looking forward to your presentation. Thank you.
Well, thanks so much, Miguel, for an outstanding introduction. I'll start with a pretty basic question, which is why are rates of cardiovascular disease so high in South Asians? And it's a question I think about every day at the dinner table. Is it the genetics or the jalebi? And it's really become a major focus of my lab's work and will be over the next few years. So I wanted to share at least some of our initial insights that we've come to related to this question. And I'll start with data led by Ani Patel, a graduating cardiology fellow in my group. And he went to UK Biobank data. It's actually one of the largest prospective cohort studies ever done. He looked at 8,000 individuals of South Asian ancestry and compared their rates of cardiovascular disease to 400,000 people of European ancestry. And consistent with the data Miguel showed, he really found a more than double the risk despite them having access to contemporary care and a national health system. And moreover, what was interesting is that this increased risk, which was more than double, was actually not captured at all by the current clinical risk estimator used in the United States, called the pooled cohort equation. And the reason for this is actually pretty simple. There were 0 individuals with South Asian ancestries that went into the derivation of these equations. We went on to look at the QRISK-3 clinical risk estimator, which is more commonly used in Europe. And this actually included a risk enhancing factor for South Asians, where you multiply the risk by 1.4 or so. But even that was inadequate to capture the risk was observed. So I think it's, again, increasingly being recognized that South Asian ancestry really is a risk enhancing factor, but yet we don't really understand fully why that is. And so we went on to show, for example, that increasing rates of diabetes, especially diabetes in the absence of obesity, is one factor. And I know we're going to hear from other speakers about additional factors that contribute to this disparity. But I wanted to focus today mostly on what have we learned about the genetic drivers of cardiovascular disease. And so this concept that genetic prediction can be useful has traditionally focused on rare monogenic mutations. And cardiologists tend to be most familiar with familial hypercholesterolemia. This is a condition where a single base pair change leads to inability of the body to clear cholesterol from the circulation. So there's dramatically higher circulating cholesterol from the time of birth. And on average, this leads about a tripling of risk for heart attack over the lifespan. And it turns out that when we look at the population, these mutations are actually present in about 0.4% of the population. And so one important body of work is actually to find and help treat these individuals. And similar proportions have been found even in South Asian individuals. But we thought there may be a new approach needed for the remaining 99.6% of the population who doesn't have one of these familial hypercholesterolemia mutations. And here, we've tried to develop new approaches, which is genetic prediction based not on one base pair change, but actually over 6 million common DNA variants, so places in DNA where my DNA might differ from yours. To do this, we derived a score based on looking at 60,000 people with heart disease and 120,000 controls. We ended up with a list for every variant. Was it associated with a 5% increased risk of disease, 2% decreased risk of disease, et cetera? And we use a sophisticated computational algorithm to actually combine information from all those variants into a single number. Now, this score, which we call a genome-wide polygenic score, as you can see here, is actually normally distributed in the population, just like things like blood pressure or cholesterol. And we went on to show in 300,000 additional people that where you are in this distribution actually has meaningful impact on your rates of cardiovascular disease. In this case, the diagnosis by the time folks reach middle age, and those folks were in their 50s or so. And you can see on the x-axis here is just the percentile of the polygenic score. So each dot actually represents 3,000 people. And look at the gradients in risk ranging from 1 to 11%, simply based on genetic variation alone. Now, the traditional approach, as I mentioned, is to compare carriers of a high-risk variant to non-carriers. And what we actually observed was that if we said arbitrarily the top 8% of the distribution is a carrier of a high polygenic score, and the remaining 92% is a non-carrier, we actually confirmed that there was greater than triple the risk. So this is a risk that's equivalent to what's observed in familial hypercholesterolemia, but it's 20 times as common. And what's interesting is that the traditional risk factors used in clinical practice are actually inadequate to pinpoint these very high polygenic score individuals. So here I'm showing you, for example, the baseline characteristics. And what you can see is that family history, as you might imagine, is 44% versus 35%. Hypertension, 32% versus 28%, and so forth. So though some of these traditional risk factors are slightly elevated, as you might expect, because they're causally associated with the disease, none are enough to be useful in picking these 1 out of 12 or so individuals out from the crowd within my clinical practice. Now, assuming we are able to identify these very high-risk individuals based on the genetics, The question then becomes, is DNA destiny? And in my preventive cardiology practice, people sometimes come to me and they say, almost everyone in my family seems to have developed a heart attack, often at a young age. And in some cases, this can even lead to a sense of determinism, where they feel like they're predestined to go on and suffer a similar fate. And I see this especially commonly in South Asian individuals. And well, I think the good news, at least our analyses today, is this is not the case. So here, initially, is some data we showed a few years ago from observational studies. I'm showing you here only those with a high polygenic score. And on the y-axis is the 10-year probability of a coronary event. And what you can see is that those who had an unhealthy lifestyle, the rate of coronary disease was about 11%, versus healthy was only about 5%. And across all three studies, there's about a 48% decrease in risk for those who had a favorable as compared to an unfavorable lifestyle. And interestingly, these individuals actually got back to the population average. They can never do as well as those with good genes and a good lifestyle, but they got to the population average, and that's been helpful even in counseling of our patients. What about medication? Well, here's similar data pooled from primary prevention statin trials, so cholesterol-lowering pills. And again, you can see that in the placebo, patients had about 20% rate of events versus in statin, only about 12%. So more than 40% risk reduction. And these papers went on to show that this is actually a unique group that benefits the most, both in absolute and relative terms, from therapy with statins. So there are two interventions that you might consider offering these very high genetic risk individuals if you're able to identify them. Now, one other question that comes up is, what is actually the interplay of this polygenic score concept with these monogenic variants, like those related to familial hypercholesterolemia that I mentioned? And so last year we went on to study this in about 48,000 people from the UK Biobank. And here on the left, I'm showing you the traditional approach. So a small subset of the population has a very high monogenic risk variant. And on average, the risk was about 41% versus 13%, about threefold risk. And here the y-axis, just a chance that folks develop disease by the time they reach age 75. And I'm now showing you what happens if you now layer in the impact of the polygenic score. And so the gray dots are the one I showed you previously, which is in the non-carriers. But look at the carriers, and you actually see that here on the x-axis again is the percentile of the polygenic score, and these blue dots show a risk gradient ranging from about 18 to 78%, even among those who have these high risk variants. And so, what I think has become clear to me is that the state-of-the-art genome interpretation really does require looking at these both monogenic variants and the polygenic score. And we think that from the time of birth, you could put people in any of these 200 dots, ranging from no monogenic and low polygenic score of 4%, all the way up to 78% for these people who we really think have a genetic double whammy. And so in terms of polygenic scoring, what have we learned? Well, first, it distills inherited risk into a single number. It's available from birth, and in theory could give a decades-long head start to overcome inherited risk. The risk prediction exceeds that of traditional risk factors like blood pressure or cholesterol. These high polygenic score individuals are definitely flying under the radar within practice, even at places like Mass General and DEBAKEY. The high polygenic score individuals are about 20 times as common as these rare monogenic variants. And even for those who have an FH variant, it modifies the risk significantly. And lastly, I think what's exciting is that from a single test, scores can be measured across a range of preventable diseases. Here I'm showing you very similar patterns across atrial fibrillation, diabetes, inflammatory bowel, and breast cancer. And so these observations really led me to say we need to start to deploy this in clinical practice. So we founded a preventive genomics clinic at MGH, really embedded within primary care, where I think the future of this type of work will be. And last December, we launched the first genomic and state-of-the-art genomic interpretation test in a collaboration with Color Health, where we really look at both monogenic and polygenic risk. And in the 50 so patients or so that we've treated so far, really the question is, if you knew which of these 200 dots you were in, what would you do? And it's been really fun to figure out how to disclose the risk and how it impacts downstream clinical management. So much more recently, we've turned to a question to say, well, can we actually build a genetic predictor specifically for a South Asian population? And one of the interesting things about genetic studies is that South Asians are actually the most underrepresented major ancestry in studies to date. So here I'm showing you is that South Asians represent 23% of the global population, but are only 1.3% of genetic studies. And that gap is actually getting worse over time rather than better. So despite that, we actually validated, at least with proof of concept, a polygenic score, again, comprised of about 6 million variants. We studied in 3,000 participants and recruited in India, but using MedGenome as a collaborator. And we carefully made a pipeline that took genetic ancestry into account. And we observed at least proof of concept that there was about a 5-fold gradient across quintiles of this polygenic score that was tuned to South Asian ancestry. But even though the predictor works, we're confident we can do even better. And this, again, as I mentioned, is a major focus for my group, really bringing together the globe's data and investigators to really enhance genetic prediction specifically for individuals with South Asian ancestry. So I'll just close with saying that number one, South Asians are more than double risk. That's not captured in clinical risk tools. Genetics play an important role, and we have proof of principle that a polygenic predictor can work, but we really need to bring together the world's data and best methods moving forward. And lastly, I think the era of preventive genomics is already here at Mass General and many other hospitals around the country. And this includes, in our case, a state-of-the-art genome interpretation test that looks at both monogenic and polygenic factors. With that, Miguel, I just thank you so much for the opportunity, and I look forward to questions either now or after the other speakers. Thank you.
Thank you so much, Amit. That was a great presentation. Thank you. And definitely a lot of questions coming up. We're going to address most of them at the very end of the session after the other speakers present their sessions. But I wanted just to remind the audience about ways to collaborate and ways to participate. If they want to join by web, they can go to poll.ev.com. They can enter the back key and respond to the activity. If they want to join by text, they can text the back key to 37607 and send their questions, and we will be very happy to address those later. But thank you so much, Amit, and I myself have a number of questions for you, so we will follow up later. But now we're going to be talking about metabolism. As I mentioned, we have Anand Rohatgi today with us. Anand has been a terrific mentor of myself in the last year. As I mentioned, he's an expert in metabolism and HDL function, advanced lipids. He's an associate professor of medicine at UT Southwestern. He's a clinical cardiologist in UT Southwestern, and he's the cardiovascular director of academic development there. And we're very much looking forward to learn more about metabolism, atherogenic dyslipidemia, and all these interesting topics with you. And thank you so much for joining.
Okay, thank you very much. It's a pleasure to be a part of this conference, Miguel, and talk about lipid metabolism in South Asians. These are my disclosures. And I want to also remind everyone in the audience, Miguel already mentioned this, but there are two statements out there, one from the American Heart Association and one from the National Lipid Association that just got published in March, hot off the press. Both are very comprehensive reviews of cardiovascular risk in South Asians, and I recommend everyone to look at them if you haven't already. So the outline of this talk will be mostly about already published literature. Most of the work has been done by others. Some of you are in attendance here today. Briefly, just talking about where does the data come from about this atherogenic dyslipidemic pattern in South Asians, the role of lipoprotein a, and then a little bit of a teaser for the work that I kind of do related to HDL function. So in terms of lipids and cholesterol, it's helpful to understand how the different classes of lipoproteins relate to each other. So you can see here that the atherogenic lipids, LDL, IDL, and VLDL, all of the cholesterol in these atherogenic lipids can be easily captured by calculating non-HDL cholesterol, or total minus HDL. They all contain the protein apolipoprotein B on them. So the total concentration of ApoB also captures the aggregate amount of atherogenic lipids in the circulation. And this also includes Lp(a). In contrast, HDL at the bottom left of the figure are the smallest, most dense lipoprotein particles. They contain not ApoB, but apolipoprotein A1 on their surface. So that's what characterizes the HDL particles. And when we think about the epidemiology of the dyslipidemic pattern in South Asians, it comes from a few sources. So I'll show just a few aggregated data here. When we look at South Asians in the United States, that's SAUS and the blue bars, you can see that the prevalence of LDL levels above 130 is actually similar to other ethnic groups. When we look at low HDL cholesterol, less than 40 milligrams per deciliter, slightly increased prevalence, and markedly increased prevalence of high triglyceride levels and high ratios of apolipoprotein B to ApoA1, the higher connoting an increased risk for atherosclerotic disease. Another way to look at the prevalence is to look at the odds of having these lipid abnormalities related to other groups when you can adjust for things like age, body mass index, socioeconomic status, smoking, and other risk factors. So that's what you see here. This is the relative odds compared to non-Hispanic whites for a variety of groups for the lipid outlined at the top. So here for high LDL, you can see here Asian Indians related relative to whites have an increased modest odds of having high LDL. And you can see that that's somewhat similar to other Asian subgroups and other ethnicities. The point estimates in bars in black are the ones that are statistically significant. In contrast to high LDL, the odds of a low HDL are 3 to 4 increase for both women and men, Asian Indians. And this is much higher relative to other Asian groups and other ethnicities. And then high triglycerides, while highly prevalent, has a twofold odds relative to non-Hispanic whites. So it is certainly increased to non-Hispanic white groups, but that increase is very similar. That odds is very similar to other Asian subgroups and ethnicities when you control for some of these risk factors. Now, when we dive a little bit deeper into the particles, the lipoprotein particles themselves, this group looked at that in a Canadian cohort of about 500 South Asians and Europeans. The South Asians in this cohort were slightly younger, and their body mass index was lower, 1 full point lower than the Europeans. Despite the lower body mass index, they had a 28% increase prevalence or levels of triglycerides. And if you focus on that column in the blue, when you look at the LDL particle characterization, while the LDL cholesterol was increased relative to the Europeans, it was pretty modest. The biggest increases in terms of the atherogenic lipids were related to the ApoB concentration and the LDL particle concentration. So for the atherogenic lipid profiling, it's mostly the total numbers of particles, the total number of ApoB, and a preference towards smaller sized particles. So this small, dense LDL particle phenotype. That was in contrast to the pattern with HDL, where the largest differences were in HDL cholesterol levels, 15% lower HDL cholesterol levels. There were lower levels of ApoA1 concentration and HDL particle number as well, but the magnitude was about half that for HDL cholesterol. So slightly different patterns related to cholesterol versus particle number and protein concentrations with South Asians versus Europeans. This study went on to also try to characterize, in terms of an observational manner, what other things were driving these differences in the lipid classes between South Asians and Europeans. And they found that there was a striking difference in insulin resistance as measured by the homeostatic model assessment of insulin resistance, or HOMA-IR. The South Asians had an 81% increased level of that marker compared to Europeans, very, very different. They also went on to measure cholesterol ester transfer protein activity, CETP activity, which is a key player in lipid metabolism between HDL, LDL, VLDL, cholesterol levels, and triglyceride levels. And they found that South Asians had significantly increased activity levels of CETP compared to Europeans, and that was in both women and men. They went on to then correlate CETP activity with triglycerides. And as expected, higher triglyceride levels tracked with higher CETP activity. But as you can see here, for any given level of triglyceride on the x-axis, South Asians depicted in red had higher levels of CETP activity compared to their European cohort. So this metabolic phenotype was clearly different in South Asians. And when you think about what's happening in terms of lipid metabolism, it kind of makes sense. So on the far left, when you're in a state of insulin resistance, there's an increased release of free fatty acids into the circulation from adipocytes. And that serves as a substrate in the liver to generate triglyceride-enriched particles with ApoB, mainly VLDL-type particles that can then get released into the circulation. This protein, CETP, can then interact with VLDL and then exchange the triglyceride from VLDL onto HDL and LDL particles, and then deliver back cholesterol from those particles to VLDL. So what you end up with are VLDL cholesterol-enriched particles, remnant-type particles, and then the HDL and LDL particles are enriched with triglycerides, which makes them subject to lipase action, which hydrolyzes triglycerides, leading to smaller, more dense particles and loss of the proteins, which explains why in South Asians and anyone with insulin resistance, you tend to see higher triglyceride levels, lower HDL cholesterol levels, and smaller, more dense particles. Focusing now on the proteins, ApoB and ApoA1, It's already been demonstrated in non-Asian cohorts that the ratio of ApoB to ApoA1 is strongly and independently associated with risk of coronary heart disease in particular. But when you look at South Asians and specifically here, this was the InterHeart study. This was a pivotal case control study of first acute myocardial infarction. On the left, you can see that for any given LDL cholesterol level, South Asians depicted in the black dotted line had higher levels of ApoB compared to other Asian subgroups. And similarly, on the right, you can see here for any level of HDL cholesterol, South Asians depicted in the black dotted line had lower levels of ApoA1 compared to other Asian subgroups. So not only does this ApoB to ApoA1 ratio predict disease in non-Asian cohorts, you can imagine here from this epidemiologic data why it might be a powerful marker in South Asian, even relative to other Asian subgroups. This study then also dove in and tried to find the patterns of the ApoB to ApoA1 ratio in South Asians compared to other groups. And what they found was compared to people from other countries, there was an increased prevalence of elevated ApoB to ApoA1 ratio. That was defined here as the highest tertile, even in the cases and controls. There was a significantly increased risk, over a twofold risk with incident AMI, and the population attributable fraction in the far right was high and similar to other countries for this elevated ratio. Within South Asians, you can see that women had slightly lower prevalence of this elevated ratio and a slightly lower population attributable fraction, but it was quite high still. And then when you subdivide South Asians by the country of origin, you can see that here, at least among controls, 1 in 3 people from India had an elevated ratio, whereas almost 1 in 2 from those from Bangladesh, Sri Lanka, or Nepal. They also then looked at age, and we know that South Asians present earlier, sometimes 7 to 10 years earlier in terms of coronary disease presentation. And what they found here was that this elevated ratio was increased in people who were ages 40 to 60 in South Asians versus other countries. In fact, 1 in 5 South Asians in this study, ages 40 to 60, had an elevated ApoB to ApoA1 ratio, which was markedly elevated compared to those from other countries. So shifting gears from general lipid patterns, I then wanted to now focus on one specific atherogenic lipid, lipoprotein a. And I'm going to point you to this reference at the top by Ines. And this is a very comprehensive and timely review on lipoprotein a in South Asians in particular. So you can see here the cartoon of the particle, the lipid-like core and ApoB concentration helps associate LPA levels with increased atherogenic risk, but it also has this large Kringle-like repeat domain that's plasminogen-like and lends itself to increased thrombotic risk and is mostly genetically determined. When you look at the epidemiology of LPA levels in South Asians in this case control AMI cohort, you can see here that the levels of LPA in South Asians were second highest only to Africans amongst the cases and controls. And while the amount of people, the percent of people who had elevated levels over 50 were somewhat similar across groups, the delta between cases and controls was magnified in South Asians. There was a doubling in the percent of people who had elevated LPA in cases versus controls. The biggest difference that was revealed from this study was the population attributable fraction, where up to 10% of the disease was explained by elevated LPA levels in South Asians, much, much higher than in other groups, regardless of the ranges of LPA in those populations. And when you look at the risk, the relative risk, the South Asians who had LPA levels greater than 50 had a twofold increased risk of myocardial infarction compared to South Asians below 50. And then when you used other thresholds, the risk was elevated among South Asians as low as a threshold of 30 in the top left corner, all the way up to a threshold of 70. So across the entire range of LPA, higher levels in South Asians connote increased risk of coronary disease. And we all know that LPA levels have been demonstrated through genetic Mendelian randomization studies to be causally associated with coronary disease. atherosclerotic disease. But one of these I wanted to mention here by Dinesh Salahin was actually derived from a South Asian cohort. So this was the PROMISE cohort of over 9,000 first AMIs in those in Pakistan. And they were able to identify genotypes that correlated with LPA levels in this group, associate them with coronary disease within the group, but also then translate the variants to larger databases like Cardiogram and show a link from the genotype variants to incidence of disease, helping cement the causality. So when it comes to lipid screening in South Asians, I think it's helpful to think about what's the population attributable risk and then the prevalence. So aside from smoking, hypertension, and diabetes in South Asians, the two lipid markers that come to the fore are the ApoB to ApoA1 ratio and elevated levels of Lp(a). And on the right, you can see here that for ApoB and ApoA1, the prevalence of an elevated ratio is 1 and 2, with a high population attributable risk fraction. So that makes a lot of sense. Elevated LPA levels, and I didn't get into this due to time, whether you use the measurement that gives you milligrams per deciliter, 30 to 50, or nanomoles per liter, 75 to 125. 1 in 4 South Asians will have elevated levels of LPA, and the population attributable fraction is on par with diabetes in South Asians, and that's assuming a prevalence of about 9 to 10%. If the prevalence is more like 25%, which is what more contemporary studies show, the PAR for elevated LPA is in fact probably a bit higher. So this is a summary table from the National Lipid Association document that just came out that shows you the desirable ranges of lipids in South Asians. And then when it comes to ApoB to ApoA1 ratio, that's really hard to extract from the literature. But this was from large studies in non-Asian cohorts that suggest that a cutoff of 0.9 in men and 0.8 in women connote increased risk, and a cutoff of 0.7 and 0.6 and lower connote a lower risk. So I think these are reasonable ranges at the extremes to think about if you're going to measure these in your patients to further refine risk assessment. So I'm going to end briefly with a teaser about the things that I do, which are related to HDL, high density lipoprotein. We know that low levels of HDL cholesterol connote increased risk of atherosclerotic disease, and the low HDL is much higher in South Asians. But the cholesterol levels don't really tell you a lot about what the functionality of HDL. HDL has multiple functions here depicted on the cartoon on the left. It helps promote reverse cholesterol transport, that is the removal of cholesterol from the arterial wall back to the liver and out of the body. It helps prevent oxidation of lipoprotein particles, and it helps mediate inflammation in various tissue types, amongst other functions. And this has direct relevance to cardiovascular disease, diabetes, and other diseases as well. And for the sake of time, I'm going to skip our own data here, but I'm going to just briefly say that the assessment of HDL composition and function in South Asians is rather limited in terms of the number of studies and also the size and scope of the studies that have been done. So because of that, and because of my interest and hypothesis that this pathway, this metabolism pathway is directly relevant to the increased risk in South Asians, Miguel, myself, and some others here as well have submitted a grant recently to focus on 4 different measures of HDL composition and function: cholesterol and an anti-inflammatory capacity, 2 main functions that are linked to the incidence of cardiovascular disease in non-Asian populations, and then in C and D, proteomic categorizations of HDL that have also already been linked to incidence of coronary disease. And we're going to take these 4 main measures of HDL and study them in MASALA, the largest cohort of South Asians in the United States, and link them to metabolic outcomes depicted on the left, as well as atherosclerotic outcomes depicted on the right. And I'd love to come back at some point and tell you what we're finding once the studies get going. So with that, I'll end, and thank you for allowing me to participate in the conference.
Thank you so much, Anand. It was a fantastic talk. And we got this question from the audience that I think is going to be very relevant to the first talks that we got from our experts. So I'm going to share it with you right now and see, Amit, Anna, what you think about this patient. So they're asking us about a 32-year-old Indian man who happens to be a cardiologist in training, by the way. They specify this information. This patient has a strong family history with father with early coronary artery disease and also positive history in both paternal uncles. But this patient has actually almost ideal risk factors. So total cholesterol is 160, LDL is 105, HDL is on the lower side, 39, non-HDL is 121, A1C 5%, BMI 20, and the patient is very, very active, they specify. They are asking us about the management for this patient. How would you manage risk in this patient who is 32-year-old, so you cannot use the cohort equations, but you have this strong family history, and they ask us about whether we would use CAC score. So that this might be Dr. Nasir asking this question. PRS, LP(a), ApoB ratio, or would you just start at Torba-10? What would be your approach as clinicians when you see this kind of patient, which I'm sure is pretty usual in your clinic, not as an exception given the strong presence of CHD in many of our patients, or in the family of many of our patients. So what do you think, Amit, Anand, Priyanka, our clinicians, what do you think about this, the management of this patient?
Yeah, thanks so much, and happy to take a first pass. Which is one, I totally agree. This is an unmet need in terms of how to counsel this patient. So, but I'll just say, based on my own recommendations, would be first, I think, moving away from what the guidelines say. I think the decision about whether or not to take a statin ultimately is a shared decision-making, personal decision. And I think a compelling case could be made for this patient as well as almost any other adult, and especially given how cheap, safe, and effective they are. So that's usually where I start the conversation, saying, given what we know about statins, is that something you'd be willing to consider? I think if the answer is yes, I would just go forward with that, because that's the most well-proven intervention beyond lifestyle. If the answer is no, that's when I think a CAC scan sometime in the 30s, and I personally do find value in the polygenic score as well. Specifically, the polygenic score can help distinguish between shared DNA between him and his father or uncles, and shared environmental factors, which may be less relevant to him.
And any thoughts about this patient?
Yeah, no, I don't have much to add. I think that's exactly right. I think if there's multiple family members with premature disease, that's a compelling family history. It's compelling enough to say it wouldn't be unreasonable to initiate statin just because of that. Measuring an LP(a) might be reasonable as in terms of inherited risk. And I agree, the genetic information could be extremely valuable. I also would say that sometimes these simple measurements come out completely normal, but often South Asians can be sarcopenic and they don't have a lot of muscle strength and ability to do cardio exercise that well. And they have underlying insulin resistance that's not captured by fasting glucose levels in particular, or even hemoglobin A1C. So sometimes digging a little deeper may not change the final decision, which is you probably should be on something like a statin much earlier in life than other people. But it may motivate possibly that individual to begin a foundation of habits in their young adult life that really will help them long term that they may not be already doing.
I couldn't agree more. This is fantastic. I would just add that we definitely need more studies in younger South Asians, in which we can understand the determinants of early atherosclerosis in this population, so that we can also inform those interventions, risk assessment. But really great question. I appreciate the audience, the questions that they are sending. Just wanted to remind them that if they want to continue participating, we will go through those questions later. They can join by web. They can go to paulev.com and they can enter the DEBAKEY and respond to the activity. If they want to use text, they can join by texting DEBAKEY to 37607 and text their questions as messages. We're looking forward to their participation. And now we're going to move on, and we have Dr. Priyanka Satish with us. Priyanka is a cardiology fellow here in Houston Methodist. And as I mentioned before, she has been leading some of the efforts from our group, our research group in the Division of Preventive Cardiology, with Dr. Nasir as the chief of the division, trying to understand a bit better risk heterogeneity among South Asian individuals, both here in the US using NHIS data, and also in Europe with the data that I shared before among different subgroups of South Asians living in Catalonia. She did a wonderful job trying to describe the potential cultural factors leading to those differences between South Asian groups, and she's going to share some of those thoughts today with us. We're very happy to have her here. Thank you so much, Priyanka. all yours.
Thank you so much, Miguel. I'm thrilled to be talking about this topic that's very close to my heart. And I hope to share some points about South Asian culture and how it can affect cardiovascular health, and go over some implications for ASCVD risk reduction in this group. I say South Asian culture tongue-in-cheek because there is no one South Asian culture. It obviously varies by region, it varies by religion, it probably differs between native and immigrant South Asians. That being said, I've tried to go over some common themes and then go over some specific scenarios. We'll start with diet, where the effect of culture is rather prominent. It is well known that South Asians consume a diet that's rich in saturated and trans fat intake. And we love cooking and deep fried items that are made in oil and ghee. There is also a hypothesis that high heat cooking, which occurs with deep frying and using reheated oil, can be associated with an increased risk of ASCVD in this group. It's also well known that South Asians consume a very high amount of carbohydrates in the form of refined grains like white rice, and we love our sweets. Another theme has been that South Asians consume a lower amount of protein than is recommended. This has been seen in South Asians in their native countries as well as in immigrant South Asians. Speaking of immigration, this group looked at the effect of immigration on dietary patterns in South Asians. What they found was, as the duration of immigration increased, there was an increase in fruit and vegetable intake, an increase in baking and grilling foods. Of course, this does vary depending on where they migrated to. For example, South Asians who migrated to places where Mediterranean diet was commonly used would integrate that into their diet, versus those who moved to areas where fast foods were more common and red meat was more common would integrate that into their diet. The MASALA group in the US looked at dietary patterns in predominantly Asian Indians, and they found 3 major dietary patterns. The first group consumed a plant-based diet that has fruits, vegetables, and legumes. The second group also consumed a vegetarian diet, but they had a high intake of fried foods, sweets, and high-fat dairy, and they had more insulin resistance. The third group consumed an animal protein and Western diet, and they had the worst CV risk factor profile. Now that we've taken a look at the major dietary patterns, let's go over some cultural factors that could influence the perception of a healthy diet in this population. So our group looked at many different healthy practices in a group of Indians. And we found many practices that, like, avoid food grown underground, like eat cereals and boiled rice, and they're good for diabetes. Things like that were common in the community. And while it's probably not okay to expect someone to know every little practice that exists in the community, I think before we counsel a patient, it's certainly prudent for us to discuss these beliefs with our patients. Going over some other cultural factors that can influence diet perception. South Asians may be unable to identify with the traditional Western diet and if it's not culturally adapted to them. So asking them to give up every sweet that they've eaten and completely give up rice may be met with resistance because they may feel devalued. And this advice conflicts with their established cultural norms. And there have been dietary habits established in the family and practiced by generations before them. So that's something we need to be sensitive to. When South Asians are asked about their challenges in following a particular dietary plan, they often mention that they have a lot of social pressure during festivals and social events, and they often find it difficult to follow a plan during those events. And going over strategies to deal with this can be helpful when coming up with a dietary plan for South Asians. It's also important to consider logistics of cooking and food preparation. When men are asked in focus group discussion, they often say that they don't have much say in what is being cooked because the responsibility is predominantly with women in South Asian cultures. Financial and time constraints are often brought up. And availability of healthy, culture-specific food can be an issue, especially for immigrant South Asians. Case in point, I found this box of gulab jamuns, which is a South Asian sweet dish, on an aisle in Costco in Houston. Whereas if I had to find a whole grain alternative to rice, I'd have to make a trip to the South Asian store and look for it there. So what can we do? Many groups have come up with different dietary plans that can help South Asians follow a healthy yet culturally appropriate diet. This was the recent paper by the National Lipid Association that came up with a plate which had a lot of healthy South Asian foods. This is a carbohydrate counting tools for South Asians, which has a pretty exhaustive list of common foods. And these are some other references that South Asians can use for healthy eating and cooking. Moving over physical activity, it's well known that South Asians follow less than recommended physical activity. It's been seen in the native countries, in Europe, as well as in the US. And there are multiple cultural factors that affect the uptake of physical activity. First of all, South Asians may not appreciate the Western construct of exercise for self-benefit. They may think it's unnecessary for people with a normal BMI, and this is changing, but it's definitely prevalent. They may not have access to exercise space. And women often in focus group discussions will say they're not comfortable exercising in mixed sex settings, and this is something that we need to address in a systematic manner. Going over smoked tobacco use, we and other groups have seen an increased prevalence of smoked tobacco use in Bangladeshi men. This has been seen in native South Asians, which is the graph to your right, and it's also been seen in our study in Catalonia, Spain. Same with smokeless tobacco use. It has been seen in both men and women. It's seen in native as well as immigrant South Asians, and there are a multitude of factors. For some, it's a connection to their homeland. For others, it's a part of their culture and it's a part of their religion. And for yet others, they believe that it actually helps with digestion rather than harms them. And hence, they may not be even forthcoming with smokeless tobacco use if we don't ask them about it. I'll wrap up with some cultural factors that might affect disease management and cardiovascular risk. Our group looked at Indians in West Bengal, India, and we asked them what they think about their disease. These were Indians with hypertension and diabetes as a part of the Sehat trial. And we found a lot of fatalism where patients would often tell us, we have no control over our disease and nothing we do can change it. Some believe this was God, others believe this was genetics, but this was a common theme. Other groups noted a lot of under-recognition of disease, where people did not believe that having a BMI less than 25 was healthy, and in fact thought that they need to eat more. And when we asked South Asians about what they think they can do to reduce their cardiovascular risk, often stress reduction is brought up. And there's a variety of factors that contribute to stress. Some of them are social, and Dr. Islam will go over them in her talk. I'll conclude with this shout out to the Saheli study that's studying an intervention to reduce South Asian CVD in a culturally adapted dietary exercise and other activities that involve the community. And hopefully with their data, we'll have more idea and understanding of the best ways to culturally adapt our interventions to improve South Asian health. With that, I'll hand the mic back over. Thank you, Miguel.
Thank you, Priyanka. Thank you so much for a wonderful presentation, very comprehensive, and actually triggered a lot of questions from the audience. I think most of them were actually addressed with your presentation. But I would like to actually ask you and maybe Anand from a Mediterranean standpoint. So you know that Mediterranean diet includes components like extra virgin olive oil. I used to recommend extra virgin olive oil to all the patients that I would see in Spain, in Barcelona, when I interact with South Asian patients trying to replace sources like ghee with extra virgin olive oil. But what about pasta? So you know that pasta carbohydrates are actually a big component of the Mediterranean diet. Would you recommend a Mediterranean diet without some qualifiers about being careful with carbs to a South Asian patient? Anand, Priyanka, what do you think about this?
Priyanka, go for it.
I think the best diet for a patient is one that the patient follows. So I'll start with that caveat. In terms of keto versus Mediterranean versus low calorie, I think I do advise my South Asian patients to at least try and incorporate as many parts of the Mediterranean diet that they can follow. And I may not necessarily emphasize the carbohydrates. I usually ask them to restrict it. And once they start counting it, they often realize that their carbohydrate intake is way above recommended. But I do recommend trying to use olive oil as a substitute, just like you do.
Great. Any thoughts, Anand?
Yeah, no, I totally agree. I think I think you have to work with the person and their family. I think the first step is just to get them to be aware of what are they ingesting. I think you're right. People aren't completely aware. And then you have to have culturally concordant counseling and advice, and oftentimes including, there's usually one focal person in the family who's doing the shopping and the cooking. So it's often helpful, if that's not the patient that you're treating, to include that person in the counseling and recommendations. And then slowly, gradually, I usually do 20% changes in behavior over a few weeks at a time. So not rapid shifts and not new concepts, but just slow changes over several weeks to months.
Okay, thank you so much. Okay, and now last but not least, we have Nadia S. As I mentioned, she's one of the PIs of the MASALA study in the New York site, and she's associate professor of population health in NYU. She's leading the efforts locally to try to understand a bit better the burden of cardiovascular disease in people mostly from Pakistan and Bangladesh living in the US. And she's an expert in social determinants of health and their impact in cardiovascular disease. So we're looking forward to hearing your talk, and thank you for joining, Nadia. It's a pleasure to have you with us.
Thank you, Miguel. It's a pleasure to be here. I just want to make sure that everybody can see my slides.
Yes, perfectly fine.
Wonderful. So I'm, truly privileged to be here today and join this panel of my esteemed clinician colleagues. And I'm here to offer a bit more of an upstream view as a sociologist, and to really understand what are the upstream drivers of coronary heart disease in the South Asian immigrant community. So let's start off with a little bit of definitions on what are social determinants of health. So the World Health Commission states that the social determinants of health are actually mostly responsible for health inequities. Those inequities that are unfair and avoidable differences in health status that are seen between and within populations. And these are determinants over which individuals have little or no direct personal control that can only be altered through social and economic policies and processes. So some of the key social determinants that we think of are things like income and income inequality, education, race, ethnicity, gender, and the related discrimination that's associated with that, but also more intermediate social determinants, things like stress, social support, social standing, and then contextual factors like early childhood experiences, employment, housing, transportation, and our environment, including both the food environment as well as the built environment. There have been meta-analyses conducted to really understand what produces health, and I think this graphic nicely demonstrates the discussion that we've been having today. McGinnis and colleagues determined using a meta-analysis technique that about 15% of all health is produced by social circumstances, and another 40% are produced by behavioral patterns, about 5% by environmental exposures, and about 10% by healthcare. But what's important to note is that things like behavioral patterns and healthcare, as well as environmental exposures, are also influenced by social circumstances. So this is a sort of a global view of what produces health, but has important implications for understanding the impact of social determinants in South Asian communities as well. And it's key to note that social determinants don't just come from nowhere, that they're really created by policies that create all types of systems of imbalanced power and privilege, that they're caused by historical practices of exclusion and discrimination and really occur across the life course, and that these determinants lead to geographic concentration of poverty. So in understanding the impact of social determinants for South Asians, I want to start with a little bit of context, and in particular, two concepts, two ideas, and they're both sort of two myths that are distinct, but they've also been mutually reinforcing. The first is the idea of Asian Americans as a model minority, that we are somehow of a higher educational status, that we have experienced lower rates of crime, that we're harder working, that we're law abiding. Now, this is an idea that was reinforced in the media as early as the 1970s. You can see here in a Times article, and really consistently perpetuated over time. The other idea is this concept of Asian Americans as a perpetual foreigner. And this is where Asian Americans are characterized as somehow other, that we are un-American, that we're disloyal, that we don't belong here. Here you can see reporting from the National Scripps Spelling Bee from a few years ago. There were 2 South Asian American co-champions, and you can see the corresponding kind of social media backlash decrying that the winners were somehow not American. So why is this important? Why am I sharing this information with you? The reason is because you're really privileged today to hear from scholars who conduct a lot of research in South Asian communities and in Asian American communities. But the reality is that most of the data that's available at national and regional levels, even data available through our healthcare systems, is not disaggregated by subgroup. And in fact, in the Asian American community is often aggregated across all populations. What that means is that much of the data that we have on health disparities is really lumping together more than 30 unique subgroups. And that's really rendering our communities invisible. And this is especially true for South Asian communities, because if you think about it, South Asians are kind of an umbrella category within an umbrella community. So as a recent American Medical Association report stated, what is measured is what is valued, and what is undercounted tends to be counted out. We see this really clearly in the South Asian community, and in particular, looking at sociodemographic differences across, these are only the 3 largest South Asian subgroups in the US. And what we see is a very clear socioeconomic gradient across Asian Indians, Pakistanis, and Bangladeshis across almost every dimension, from nativity, years lived in the US, from median household income, to the percentage of those living in poverty, the percentage of those who have limited English proficiency, educational attainment, home ownership, and health insurance access. So for the remainder of my time today, I'm going to summarize some of our key knowledge regarding the impact of social determinants on CVD for South Asian immigrants. And I would like to note that the majority of the evidence that we have generated on this does come from the MASALA study, which, as has been noted, is the nation's only longitudinal cohort study of South Asians in the US. And some of the work I'll be sharing is also generated from our team in New York City, which is home to the largest and most diverse group of South Asians in the United States. So in terms of understanding social determinants, the impact of social determinants has been investigated predominantly in the following domains. The first is the area of migration. And I think researchers who are understanding health disparities in South Asians have really understood that migration is a major source of social stratification and really contributes to the patterning of health inequalities by influencing other spheres of social life and neighborhoods that South Asians live in. So by neighborhoods and social contexts, we really are referring to those contexts where South Asians are born, where they grow, live, work, and age. The other key area of research on social determinants has been in regards to acculturation, and Dr. Satish shared some important findings on how acculturation may be impacting health behaviors. So broadly, acculturation is the process of cultural and psychological change that occurs when members of 2 or more cultural groups interact. In the South Asian context and in the literature that we have, there are several common dimensions of scales used to assess acculturation that has included language and language use, immigrant status, family and friendship networks, as well as cultural practices. While, studies have generally used kind of proxies of acculturation to really understand its impact on health and health behaviors, recent frameworks have really called for a more critical appraisal of acculturation and an understanding that it's very much a multidimensional process. Again, that acculturation doesn't just happen, but it is influenced by immigrants' experience of discrimination, by the heritage of both their sending and receiving communities, as well as concepts related to ethnicity. And finally, another key area of research in social determinants has been on the role of discrimination on health and the role of discrimination on CVD in particular. So let's go over a brief tour of what we know. Studies from MASALA have demonstrated that higher acculturation is associated with better mental health outcomes and also with CVD risk factors among women only in the South Asian community, as well as in the Asian Indian community from some of our work in New York City. Again, studies from MASALA have also found that higher acculturation is associated with more physical activity and better diet quality among South Asians. Looking more upstream at kind of neighborhood level factors, we've done some work in New York City looking at a very large sample of Asian Americans that are part of our hospital system. This was a sample of almost 30,000 patients, and we found that diabetes prevalence was highest among Pakistani and Bangladeshi patients in our sample, exceeding all other Asian as well as non-Asian groups. But what was most interesting in regarding neighborhood context was that there was consistent evidence of an economic gradient, whereby persons residing in the most privileged neighborhood tertiles in New York City had the lowest disease prevalence. And this economic gradient was particularly strong for diabetes among the Pakistani community, whose prevalence in the most deprived tertiles exceeded that of the most privileged by almost 10 percentage points. There's been some important work from the MASALA study on understanding neighborhood walkability and the ability to walk to work for transport, and that this is associated with greater physical activity in South Asian men in particular. And then MASALA has also provided some really important evidence on how neighborhood social cohesion impacts health. And so what we mean by that is among the individuals in your neighborhood, how closely connected are you to them, and how might that impact your health? There have been some mixed findings in this regards. What MASALA studies have shown is that South Asian women living in neighborhoods with the lowest social cohesion had significantly higher BMI than women living in neighborhoods with the highest cohesion. However, the association was not statistically significant. Similarly, a MASALA study also found that South Asian women living in neighborhoods with high social cohesion had very reduced odds of having hypertension than those living in neighborhoods with lower social cohesion. And in our own work in New York City, we found that a 1-unit increase in neighborhood social cohesion score was associated with increased odds of recent preventative screenings, including screenings for high cholesterol, for diabetes, as well as for depression. And finally, thinking a little bit about environmental exposures at the neighborhood level, studies have found that an increase in the proportion of Asian residents in census tracts has been associated with higher levels of outdoor carcinogenic hazardous air pollutants. And neighborhoods with higher proportions of Chinese and Koreans face the greatest risk, but this was followed by South Asians. So that was at the neighborhood level, but another important social determinant is this idea of who you know and who you're getting support from. So both your social networks as well as social support and how that's impacting your health. Again, evidence from MASALA has demonstrated that the social network size and the health of people in one social network is strongly associated with CVH in the Asian Indian community in particular. For example, their analysis found that a one-person larger social network was associated with higher odds of ideal cardiovascular health. Similarly, reporting an alter or somebody in your social network with high blood pressure was associated with lower odds of having ideal cardiovascular health, similarly with cholesterol. We've also found that network member characteristics and their perceived dietary behaviors are correlated with dietary patterns of those in your network. And thinking outside of your immediate social network, but thinking more broadly about organizational affiliations, MASALA studies have also found that affiliation with religious and spiritual organizations was perceived as beneficial to health, and emotional closeness with network members is positively associated with participants' self-rated health. And finally, another key area of evidence on the impact of social determinants on CVH is in the area of discrimination. So discrimination has been associated with poor self-reported health in the Asian Indian communities. And self-reported discrimination has been unrelated to certain health behaviors, such as fruit and vegetable intake, but is positively associated with consumption of sweets per week. We've also found that discrimination is associated with decreased well-being and increased stress among South Asian Americans. And similarly, in our work in New York City, we found that among South Asians, highest depression risk is associated with high levels of discrimination. So one challenge in the research to date has been that measures of social determinant that are related to sociocultural context, things like immigration factors, socioeconomic position, and neighborhood context, have really been examined separately from measures related to individual context. So thinking about things like acculturation strategies, the resilience that communities may possess, as well as interpersonal factors like discrimination. But there's a real need to understand how these far upstream drivers independently as well as interactively influence health outcomes within individual contexts. So we are happily going to have an opportunity to do this with an expansion of the MASALA study. We will be adding a site in New York City, and this will allow us to do two things. The first is that the MASALA study currently has a majority of Asian Indian participants. And so there really is not opportunity with the current cohort to understand differences by South Asian subgroup. In New York City, we'll be adding predominantly Bangladeshi and Pakistani participants. And so we will have the ability to look at differences in CVH as well as CVH risk factors, both upstream and more behavioral and clinical risk factors by subgroup ethnicity. And we will also have the opportunity to really understand these multi-level drivers of health outcomes in South Asian immigrants. And so I'll just end with some opportunities, and I think there's really a wealth of opportunities when it comes to understanding upstream drivers of health for South Asians. There's a clear need to really think about applying an intersectionality framework as well as perhaps using mixed methods. I was really pleased to see Dr. Satish's data using qualitative methods to really understand the intersection of ethnicity, culture, socioeconomic status, and other socioecological determinants. There's a need to differentiate the kind of co-ethnic neighborhood types, such as ethnic enclaves, as well as ethnoburbs, and how these processes and how spatial assimilation in these neighborhoods may be related to health and health risk. I think one large area where we do not have very much data is understanding occupational housing, as well as environmental disparities and their impact on health in South Asian communities. And then while I think the MASALA study has really informed our understanding of social network typologies in the South Asian community, there could be more work done understanding the diversity of these typologies, the quality of social support, as well as the positive and negative effects of social support and social networks on health. Building on some of the research looking at the influence of religious affiliation in organizations, asset-based community mapping, and how affiliation with organizational and community level networks impacts health is another important area of research. And then finally, the new area that we will be embarking on is really to understand the interplay between resilience, acculturation, and discrimination. So really understanding the relationship between acculturation and discrimination on health, and really thinking about a more nuanced way of measuring discrimination among Asian Americans and the health implications of discrimination at multiple ecological levels. With that, I'll end, and I'd just like to acknowledge my colleagues and team that works closely with me on these initiatives, and I'm happy to take questions.
Thank you so much, Nadia. It was a fantastic talk. I think always very important to get the view of the social epidemiologists when we're talking about populations at increased risk, when we're talking about underserved communities. And I think in these kind of conversations, having the view not only of clinicians, of course, but also the social epidemiology researcher is very, very enriching. So thank you so much for this wonderful presentation. And we have a last question. We are running out of time, but I think this is going to be a perfect fit for Nadia. Actually, someone from the audience, they were asking about potential interventions at the population level in South Asian communities. Would you favor intervention based on interventions using medications like statins or even polypills in broad South Asian communities based on this increased risk among South Asians? Or would you favor interventions maybe more focused on this kind of interventions, focus on the trying to address discrimination, racism, neighborhood characteristics, poverty, unemployment? What would be your approach as a social epidemiologist?
Sure, great question. Well, I think it's very clear from this panel that a multi-level approach is critical in truly advancing population health. I think, we don't understand enough about how policies are impacting and driving health disparities in South Asian communities. And so that's an important area of research. I think much of my research really focuses on how we can better connect communities to healthcare systems and other systems of care in ways that are culturally adapted and socially acceptable. And so I think working closely with trusted gatekeepers, with community organizations, and with other community stakeholders to adapt interventions, make them relevant for the populations that we're working in, in both clinical and community settings is really key.
Oh, thank you so much, and congratulations on the MASALA expansion, which is going to bring a lot of great opportunities for research moving forward. I want to thank our speakers, our panel, the audience. We had a lot of people connected to the session today. It has been a great pleasure to have all of you with us, and we look forward to working with all of you in this space, which is very meaningful for all of us and definitely close to our hearts. So thank you so much, Nadia, Priyanka, Anand, Amit. I'm looking forward to future work together in this space. Thank you so much, and have a good night. Thank you.